Hello, everyone. I want to welcome you all to the fourth and final session of the inaugural Philip R. Lee Health Services Research Symposium. I'm George Sawaya. I'm the director of the Center for Healthcare Value, and I will be your moderator for today's panel session. So I first want to give you a bit of an insight into the Center for Healthcare Value. We have three main missions. One is education, the second is research and policy, and the third is health systems improvement. We have many leaders in our center, Ralph Gonzalez, Kat Lau, Jahan Fahimi, and Joanne Spetz. We sponsor several programs throughout the year, all of which are related to our mission areas. The first is the Teaching to Choose Wisely initiative, which focuses on education and make sure that all educators at UCSF have the tools to practice and teach the principles of healthcare value. We've just launched the Research and Policy Initiative, which is new in 2020, which has been mainly focused on the healthcare value implications for the COVID-19 pandemic. And we, of course, have what I would consider one of our main programs, which is Caring Wisely, that will be the focus of the panel coming up. We have also some new contests that we sponsor throughout the year. One of the most recent ones is decreasing out-of-pocket expenses for patients. And we will post all of these on our website. So please check out our website. It's probably easy to just do a Google search for UCSF CHV, and you can see what our programs are all about, and hopefully take part in the programs that we sponsor throughout the year. I want to spend just a few minutes talking about healthcare value, and probably everyone uses a bit of the same definition for healthcare value, and it's generally healthcare outcomes achieved per unit cost. But all of the outcomes and the cost can be defined from various perspectives. The first is the societal perspective, where we want to maximize good outcomes, but in general, minimize the costs of healthcare. The second is healthcare systems, where we want to minimize costs within healthcare systems so that we can allow the funding of other local initiatives that might be geared toward closing disparities in healthcare and other priorities within the healthcare system. The third is thinking about the lens of the patient, where we're trying to improve outcomes, but also enhance their experiences in care. And part of that is minimizing out-of-pocket expenses for patients. There are several ways to improve healthcare value, and I'm going to focus on the part where we're thinking about outcomes that matter to patients as the numerator, and the total cost of care is being the denominator. The first is improving outcomes for patients without raising costs. And we can simply do this by enhancing this experience of patients while they're in our care. Another would be maintaining good outcomes while decreasing costs. And probably the most low-hanging fruit in this area is just simply decreasing medical waste, or waste that we have in all aspects of the care that we deliver. The third is improving outcomes dramatically for a smaller increase in cost. And remember, it's not all about cost savings with healthcare value. We're trying to really, we're very willing to spend money if we get a lot of improved healthcare outcomes on the other end. And one way of measuring this is through the defined science of cost effectiveness analysis, which will be part of the presentations today from our panelists. And the fourth is maintaining good outcomes while decreasing costs. This is what we're all trying to do. And as you can imagine, if we simply improve the patient's experience in care and also decrease waste, we could be achieving this particular objective. So today's panel is focusing on improving research in healthcare value at UCSF and beyond. And we have three panelists. The first is Kat Lau, Associate Professor in the UCSF Department of Medicine, Director of the UCSF Health's Caring Wisely program, as I mentioned. And she's going to focus on opportunities to leverage the program's success to accelerate research in healthcare value. We also have Leslie Wilson, Professor of UCSF Department of Medicine and Pharmacy and Director of the Program for Pharmaceutical Economic Policy Studies. She's going to focus on examples of different methodological approaches to assess healthcare value. And we have Tracy Lynn, Assistant Professor of Health Economics in the Institute of Health and Aging and the Department of Social and Behavioral Sciences, who will focus on challenges in conducting a cost utility analysis on a pediatric population and her team's experimental approach to research in measuring healthcare value. So we're going to start with our panel session now, and I'm going to turn over the microphone and the slides to Kat Lau, who will tell us about the Caring Wisely program.
Thank you, George, and thank you for inviting me to participate in the panel today. It's a pleasure to be here on this virtual stage with these really accomplished colleagues. And today, my goal will really be to focus in on briefly describing our Caring Wisely program at UCSF Health, which the UCSF Center for Healthcare Value provided seed funding for and remains a critical partner in ensuring our success. So the rationale of Caring Wisely really focused on three main principles. The first, as George has described, healthcare costs is an issue both to our patients and also to society, and importantly also to the health systems that we work in. And it's very increasingly recognized that academic medical centers in this country do drive healthcare costs and are a large contributor to healthcare costs in this country. We also know that there are lots of interventions that can be done that can result in local savings. And hopefully those local savings, as George had mentioned, can also be reinvested back into the system to continue to improve outcomes for our patients. And lastly, we know from many years of experience here at UCSF and also nationally that oftentimes the most successful and sustained interventions really involve those who are engaged in the front lines. Rather than having a truly just a top-down approach, having a bottom-up approach that is appropriately supported by those in leadership for barrier removal and obviously support is incredibly important to continue to do this work. And as I had mentioned, our Caring Wisely program did receive seed funding from the Center for Healthcare Value, and we're very thankful for that and the trust that they placed in us to demonstrate that this could be a successful program. So our main objectives are to, one, allow frontline providers to identify the hotspots of waste and inefficiency and low value care in our health system. These teams can work in the clinics, they can be in the inpatient setting, they can be in the operating room, basically any area within UCSF Health that delivers patient-facing care is really eligible to identify these areas of hotspots and waste and submit their ideas for implementation. So this particular graphic was an example from the first year of Caring Wisely, where a team focused on non-evidence-based packed red blood cell blood transfusion. And they identified using this heat map the service areas that really weren't following the packed red blood cell transfusion guidelines nationally and where there were opportunities for improvement. By crowdsourcing these hotspots from the frontline providers, we then really help incubate and guide these ideas through a project contest and also through an implementation year where the projects are supported with multiple different avenues to ensure that their ideas actually become a reality and that we have objective ways of measuring their impact over the course of the Caring Wisely year and beyond. And lastly, one of the big focuses of the program is to really focus on the return on investment to the system. So we invest $50,000 in these project teams every year, and our goal is hopefully to achieve at least a 2.5 times return on investment through direct cost savings to our health system. So how do we do this? I provided the hyperlink because we actually are in the middle of our project contest this year. So I encourage all of you here to check out the website on open proposals and potentially submit. So we start out with what we call our letter of intent process, where again, we ask folks working in clinics and in inpatient settings, the operating room, to identify the hotspots for value improvement. Our letter of intent is pretty straightforward. It's only 2 paragraphs long. We don't expect this to be a very long and lengthy process. And to date, over the past 8 years, we've generated over 200 ideas. We do select the top 5 ideas, but all who do submit an LOI are eligible to proceed to the full proposal phase, which will be launching in March of this year. And it's a 2-month iterative process. The application, again, isn't onerous. It's no more than 4 to 5 pages long and follows what we call A3 thinking at UCSF Health. And a key component of this is we ensure that there's a lot of multidisciplinary team building involved. We ensure there are key stakeholders pulled into the teams if they weren't already included to begin with. And we also do some financial vetting of the possible project proposals as well. And on any given year, we get about a dozen to 2 dozen proposals submitted. And as I had mentioned before, teams are selected and funded up to $50,000 over the course of a year. And we do select 3 project teams a year. So in terms of examples of prior Caring Wisely projects, this is just a small listing of the now 23 projects we supported over the past 8 years. But you can see they come from multiple different disciplines across the hospital, include pediatrics and adult medicine, and really focus on themes when it comes to reducing waste, reducing the use of certain products in the hospital, such as packed red blood cell products or IV albumin. Really focus in on using best practices such as the neonatal sepsis calculator or promoting antimicrobial utilization and stewardship, and also focus in on creating new pathways through our health system to optimize patient care. So in terms of what we do, we have an executive committee that consists of health management leadership in our health system and in the School of Medicine, and they focus really on barrier removal. Sometimes there are just things that come up that the project teams feel like maybe perhaps they can't directly influence or really remove those barriers. And so it's really helpful to have health system leadership on our team to help with that barrier removal. And we also have an implementation science team, and we support weekly works in progress sessions. We help provide project management to the teams. We give them data and financial analytics access, really focus in on implementation science, theory-based intervention design as an aspect of how we do some of this value improvement research, and really adopt A3 thinking and rapid PDSA cycles. So I adopted this slide from one of my mentors, Dr. Ralph Gonzalez, and we use what is called the pre-seed proceed implementation science model in Caring Wisely. And really we focus on 3 main themes when it comes to behavior change. So we think about what are potentially the predisposing factors we have to really impact on project teams. So what knowledge, attitudes, or motivation we have to really design around to ensure that those we're asking to do some sort of behavior change will actually want to do the change. We also focus on enabling factors. So are there things that we can facilitate in folks' workflows, automate, or integrate into the workflow so it makes it easy to do that behavior change? And then we also really look at the reinforcing factors. What sorts of data, audit, and feedback do teams need? Are there rewards that need to be provided, social gamification, operations leaders that can help so that folks on the front lines who are being asked to do the change ultimately like the change when they do that behavior change. So in terms of our results, just to wrap things up, we are a current part of the UCSF Health Value Improvement Program. And we are also a pilot site for the use of a financial analytic platform that we're adopting now at UCSF Health to better bring transparency to our financial analytics. It's called Tag Bio. I had mentioned we've now supported and implemented 23 projects over the past 8 years. And over that period of time, in 7 years, we've had direct cost savings of about $7 million to UCSF Health. And these numbers are vetted by UCSF Finance, so it's not things that we just pulled out of a hat. We've had multiple abstracts presented at local, regional, and national meetings, at least 4 peer-reviewed publications at this point, and 2 more publications currently in process. One of our recent teams called the Integrated Spine Service, where they really focused in on a multidisciplinary biopsychosocial model to help treat lower back pain patients, was awarded a $35 million NIH grant following the Caring Wisely Year program. So, and they really attributed the success of their Caring Wisely Year to lay the foundation to receive this grant funding. And then this year, 2 of our prior recent Caring Wisely projects are also partnering with Mark Pletcher and Ralph Gonzalez, Andy Auerbach at CTSI to really do some more research with interrupted time series analysis and an embedded randomized control trial in APEX to further look at the impact of their interventions on our health system. So if you have any questions, feel free obviously to ask in the Q&A, but I'm also happy to field any questions via email as well. Thank you.
Great. Thank you, Dr. Lau. That was really an excellent overview. And it's also great to see how some of these projects do lead to other larger projects, some of which almost certainly have research implications. And perhaps at the end of the panel, we can talk a little bit more about that explicit link between the Caring Wisely program and research. But I want to move to our next panelist, Leslie Wilson. So go ahead and launch your slides, Leslie.
All right, I'm Leslie Wilson. I'm also glad to be here. I'm going to talk today, since I'm a health economist, I'll talk about some economic methods that I use in my research to determine healthcare value. And essentially, I'll talk to start with about a technique called time-driven activity-based costing, which is used to assess models of healthcare. And then I'll talk about cost-effectiveness analysis, which is mainly used to look at efficiency of new treatments. And I think I'll leave the behavioral economics work that I do with the FDA to the final speaker, who will talk about that more in discrete choice. So first to start, time-driven activity-based costing is a method that's used really to define value across care bundles. And it's a method that's used more on the practice level. And you can see by all of the partners listed here of all the people, big players that are beginning to use this technique in order to define the price for bundles of care. And the method starts with defining episodes of care for a particular type of care need, and then going through this four-step process. First, determining the care process by defining the activities over a care cycle, who performs each activity, how long does each activity take, and then calculating the cost per unit of time for each type of personnel that's delivering the care, accounting for and costing the materials, supplies, and drugs consumed during the cycles, and also looking at the indirect costs that are drivers for that. So here's an example of one study that we did using time-driven activity-based costing to improve the value of dementia care delivery. And we made these process maps. Here's an example of one of them across three different types of care practice models: accountable care organization, medical home, and then neurology medical center. And so we costed these three types of care using this technique. And you see that we found a large variability across dementia treatment sites. On the left, you can see that this is across different practice models. So you see that the ACO model costs the least amount of money across that episode of care, and the neurology medical center the most, and medical home is somewhere in the middle. And this is appropriate because they see different kinds of care, but you can see that they differ a great deal on the amount of medications, on the ancillary personnel, the purple area, and how much neuroradiology is used. And you can see that the conclusion from this is there needs to be a lot more work of integrating care across these three models. And then the figure on the right shows within ACOs, if we interviewed and did this costing across 5 different ACO models, there's still variation. And mainly this is around the amount of medications used, how much neuroradiology is used, how much ancillary cost is used. So here again, it highlights places where you can make changes in delivery to be more efficient. So I'll move to quickly talk about another technique, cost effectiveness. We can sort of all agree that financial toxicity has become a real issue, especially for cancer patients. It's a big burden for them, and they sometimes have to hold up rent money to pay for their medications. And the approach that has been used to look at the value of new technologies, new treatments that come out, is to do cost effectiveness studies. And this is one that we did looking at the cost effectiveness of a new treatment, ribociclib, versus the standard treatment in H2 negative breast cancer patients. And essentially what we do, you can see, is we model the care using Markov model, and we compare the new treatment and the old treatment across these health states of stable, progressed, and dead. And then we calculate the cost across different cycles of care for the lifetime, as well as the quality adjusted life years saved. And so you can see in our result table, whoops, you can see in our, you can see in our result table that the new treatment, ribociclib, costs quite a bit more, $385,000 compared to $67,000. And the effectiveness, though, is also more, 5 years of quality adjusted life years as opposed to 2.8. And so our bottom line, we get this ICER number here of $129,000. That's the additional cost per each additional quality adjusted life years saved. And that's considered to be cost effective for cancer treatment. And so moving on from there, let's see how cost effectiveness, or this incremental cost effectiveness ratio, how successful it has been in the COVID era. Gilead came out with its remdesivir treatment, and the economists went after assessing what should the price be. And so the first headline was across economists, the suggestion for cost was either less than a movie ticket or impossible to overpay. Experts named their price for remdesivir. So the first price, there's ICER organization, which calculates cost effectiveness studies for society, said that this drug should cost $12.50 per person. And they did this by focusing on what is the cost of manufacturing plus a regional margin of 25%. And so that's how they went about it. They decided manufacturing would be 93 cents per day or $10 for a course of therapy. And with the 25%, they said $12.50 per patient. So that's quite low. Let me remind you, though, that they were granted this emergency use authorization, and here's the JAMA results. Their results were pretty weak. They didn't meet their main outcome of 11-day improvement in clinical outcome, but they did have a strong 5-day improvement in clinical outcome. So these estimates are based on sort of a not very strong outcome, and that is improved. So ICER reconsidered because a new headline came out that says it's impossible to overpay for a truly effective drug. And so the focus was changed for ICER, and they said, redid their calculations, and they included, this time they said, even if we can get people back to work faster, just for a few days, the potential value across society would be in the billions. And so they redid their calculation, and their new suggested price was $4,500 based on including these new factors. But of course, then the headline was a price that works on paper but fails to account for reality. And so people were suggesting that this should be priced more as a utility instead of based on these kinds of efforts. And then finally, another consideration, which is important, was the need to encourage manufacturers to continue to develop drugs and vaccines for COVID. And so the suggestion then became, let's find a sweet spot between providing incentives for manufacturing, but something that doesn't give them too much reward. And so then there was a suggestion based on that of $1,000 per patient. So finally, what did Gilead decide to price its product for? And you can see over here, they came up with two prices, a government price of $2,340 per person, and a little bit higher price to private insurers of $3,120 per patient. And patients were not paying for this. This was just the insurers and the government that would pay for it. And so therefore, this is what they came up with for their final price. And the result is a price somewhere between a movie ticket and impossible to overpay. So it's an example of how economics is used in real life that we're going through right now.
So my plan is to have all the panelists speak, and then at the end, we'll have our Q&A session. So let me go ahead and move on to Tracy.
Hello, everyone. Good afternoon, and thank you so much for including me on this panel. Building on Leslie's presentation on healthcare value, I will be discussing our team's work in leveraging a discrete choice experiment to evaluate quality-adjusted live year proxies for caries in deciduous teeth that's currently available in the literature. This component of the study is part of a larger study called Behavioral Economics for Oral Health Innovation. The study is funded by NIH and NIDCR. The core study team for this component of the study includes Dr. Stuart Gansky, Dr. Francisco Ramos Gomez, Program Manager Helen Lindahl, and dental students Nicole Air-Baron and Damari Serati. So as Leslie mentioned, cost effectiveness analysis is used to determine the incremental cost effectiveness ratio of an intervention compared to the standard of care or an alternative. A cost utility analysis is a specific type of cost effectiveness analysis that evaluates the cost per gain in quality adjusted life year, QALY. By standardizing this unit, it allows for meaningful comparisons between interventions across a wide range of health services. For example, we can compare the cost effectiveness of an oral health intervention with a mental health intervention. Generating QALY for a cost utility analysis requires elicitation of preference measured in terms of utilities. Measuring utilities and deriving a valid QALY is a lot of work and especially challenging for pediatric health states. To illustrate this challenge, allow me to provide a couple examples of common methods used in determining measuring utilities. The first is the time trade-off method, in which respondents, whether they're patients from a specific population or from the general public, are presented with hypothetical scenarios of life A and life B and the time they would be in each state, and asked to pick which one is better. In this type of method, the time for these scenarios would vary until the respondent is indifferent between the two. The information is then used to calculate utilities. In a similar but lesser used method called the better than dead method, respondents are asked to imagine if they have a year to live in state A, after which they decease, or in state B, which is equals to dead. Which one would they prefer? Now, as you can imagine, administering these type of questions to young adults and children is quite challenging, and there are a lot of barriers to asking them these type of questions. As such, the field has developed the Child Health Utility CHV-9D, which is a preference-based health-related quality of life survey for soliciting preference of young adults. And in these surveys, children would be asked how worried they are, sad, how much pain they feel, if they have any issues with completing schoolwork or homework in a specific day. While CHV-9D is a step forward, there are still various challenges with using CHV-9D. First, it's very labor intensive. To minimize recall issues, children and young adults in the study would have to be asked those same questions repeatedly every day for a long duration amount of time to collect enough information to generate utilities. From studies that are currently available, we also know that there are sensitivity issues with determining utilities for the pediatric health state of caries and obesity, in that the utilities, there's no statistical significant difference in utilities for children with caries and without caries, and similarly with overweight and obesity. To complicate the issue for our particular study, we're interested in primary teeth, one that falls out and get replaced by adult teeth. So we would be, if we were to administer this questionnaire, it would have to be to young adults and, well, to children younger than 12 years old. There are ways to circumvent this challenge, and a lot of times adult preferences are brought into the picture, whether it is to apply adult utilities to child health state or ask adults to answer 29D. So you would ask an adult to imagine you're 10 years old and you have cavity in your teeth. How worried are you? How sad are you? How much trouble are you having in completing your work? And obviously asking adults to imagine that they're a child and present their preference that way could lead to different kinds of biases. As such, given these issues, for the past 20 years or so, many cost effectiveness and cost utility analysis looking at intervention for primary teeth rely on proxy diseases. And what that entails is knowing that it's hard to measure utilities in the children population. Researchers look at diseases deemed similar enough to childhood caries with utilities or qualities that can be used, and then use that essentially to replace utilities and qualities for caries. And for our particular study, the question is, how valid is that? There are so many different proxy diseases. There are other diseases with utilities similar to the proxy diseases, but not used as the proxy diseases. Could we find some evidence to add to the qualitative evaluation that these proxy diseases used in cost utility analysis are valid? Or could we provide a better range for estimating the utilities? To do so, our team decided to leverage a discrete choice experiment, which is a survey-based data preference technique to quantitatively investigate individual preferences. The technique assumes that an individual acts rationally and always chooses the best alternative with highest utility. Assumes that a good service, a health state, can be described by its characteristic, which is called attributes, and the variant of that characteristic or attribute levels. An individual's preference is determined by the level of these attributes, and we can solicit the relative importance of these attributes by assessing by presenting different scenarios and questions to respondents and ask them to pick the preferred alternative. For us, on top of the attributes and levels, we are actually more interested in how the proxy diseases compare to caries and the different stages of caries. So what we did is we conducted a literature review. We identified the proxy diseases commonly used for cost utility analysis for childhood caries, as well as examined studies with utilities that are similar to caries and utilities similar to the proxy diseases used. And we put these diseases into different scenarios and profiles and surveyed parents and primary caretakers of children between age 1 and 12, and essentially asked them, imagine if your child is sick and you can choose a disease for your child, which one of the following is better? So they are presented with 16, we randomized the profiles. So there are 15 diseases plus 5 stages of caries. And there are different attributes such as level of discomfort, duration of disease, and treatment costs with varying levels under each of these attributes. And each parents were asked to compare 18 different profiles. And what we found in our preliminary results is that there's no evidence to suggest otitis media, which is the most commonly used proxy disease, is not a suitable disease. So the sort of a good news for us, the proxy disease, there's no evidence to suggest that it's different. We also found that other similar diseases that can be used sometimes are statistically significantly different from caries. Notably, caries stage 2 was preferred by parents over acute tonsillitis and acute gastritis. So that tells us that these two diseases are probably not the best proxy disease to use in our cost utility analysis. We also found evidence congruent with the discussion highlighted in current literature that the answers to these questions, the choices that parents and respondents pick, depend on their experience. And just to illustrate this, we look at two subsamples. One subsample with are from parents who reported that their child has a developmental disability versus those who report that their children do not have any developmental disability. And the other sub-analysis looked at parents who are participants of the California Special Supplement Nutrition Program for Women, Infant, and Children, WIC, and a group that are not participants. And what we found was that so here is a plot with the odds ratios and 95% confidence interval. And we found that for parents who reported their child does not have a developmental disability, they rank pain quite consistently. They prefer their child to have a disease, God forbid, that has the lowest pain level, which makes sense. No parent will want to see their child suffer. However, this pattern is not statistically significant for parents who reported that they have a child with developmental disability. So this suggests that in the subgroup of parents who have a child with developmental disability, they have other attributes that they're valuing that's not captured in our study. Similarly, looking at WIC participants and non-WIC participants, we found that WIC participants value sort of rank pain more consistently, whereas for non-WIC participants, they seem to prefer the higher cost treatment. So the baseline is actually up to $100. So for non-WIC participant, they value more expensive treatments than less expensive treatments, or diseases that can be treated with more expensive treatments. And we think that has something to do with what they think is a better treatment or what they think is more effective if the disease were to happen to their child. So much more work needs to be done, but we're very excited about sort of being able to at least provide some evidence to validate these proxies that's been used in the literature. Thank you so much, and I'm happy to answer any questions.
As someone who has a research program that includes cost effectiveness analysis and utility measurement, just it seems to be this perfect blending between trying to understand patients' experiences and their preferences and their values, and how that intersects with costs. And just the whole concept of trying to measure that and integrate that into the value equation is so critical, but it's very challenging. As you've laid out many challenges, especially in the pediatric population, I want to make sure that we prioritize in the Q&A session, and perhaps we'll circle back to this, some of the questions that have come into our Q&A panel. And I'm going to start just by a question that has been raised by an anonymous attendee, and this is directed to Dr. Lau. And the question is, I'm curious how you view the intersection between quality improvement and implementation science for Caring Wisely projects. And so, Kat, I'm going to turn that over to you.
Sure, that's a great question. So my background is I don't consider myself a capital R researcher as my colleagues Tracy Lynn and Leslie Wilson are. I did get quality improvement training as a resident and really focused in on building my own skills as a junior faculty member at UCSF. So implementation science honestly was something new to me about 5 to 6 years ago. And what I have learned over time is that they really are not two separate entities. It's actually one and the same. The whole goal of implementation science, the reason why the field was really established, was to try to narrow that gap between what are perceived as best practices and what are actually current practices. And that ultimately is what quality improvement is all about as well, which is narrowing what we call that quality gap. There may be different terms, different vocabulary, different mechanisms of doing so, but we have really designed the Caring Wisely program so it really incorporates what I view as the best of lean and PDSA cycles, kind of traditional QI, if you will, with implementation science. Specifically, what we really lean heavily on in implementation science is that theory-based design, as I shared, using that pair framework when we do our gap analyses and our countermeasure design. We also really focus in on building logic models as well to really focus in on what are our short-term, intermediate, and long-term outcomes and how we will measure those outcomes. So really excellent question.
Great. We have a question from Catherine Phillips. Catherine says, remdesivir is a fascinating story. To what extent do you think this is because it's for COVID? Do we see the same issues with pricing with other drugs and treatments? What are solutions? Should we have a national agency to do technology assessments, economic evaluations of drugs and interventions to determine the appropriate price? Or should we leave such studies up to groups like ICER? So I will have Leslie weigh in on that, and I have a few comments about that I could put in as well.
Yes, thank you for the question. The ICER organization, as well as other groups, did a lot of these studies, and there's an ICER organization in Boston area and one here, and I think one in the Midwest, and they're doing independently these studies. But you can see what kind of range that they came up with when they did their study, 1250 versus 4,000. But I think overall, all of these studies did provide value on all the different levels that are important to consider. But there have been other issues with cost effectiveness with Hep C, which was very cost effective, but also very costly to the system. So cost effectiveness analysis is not the only consideration when you're trying to look at price and things like that. As far as having a national group, such as the one in UK, I think those can have some value, but we have some different considerations around pricing here in US that we're not sort of allowed to collude on price, which sometimes this can lead to that. And essentially what the UK organization has resulted in is really just a site for negotiation around price. And so that's less helpful, I think, for determining what a good price is. And I think in US, we would be reluctant to allow negotiation around price in this manner. So I think that leaving it up to the private, maybe providing more funding for these studies would be good, but I think it worked out well over all the studies.
Right. Yeah. So thank you, Leslie. I was going to, of course, bring up the NICE group in the UK where it is mandated. Of course, the system is so different, right? It's a closed system by and large. So there is one idea that there is just one source of funding for healthcare, and there's a lot of incentive to try to understand the judicious use of those funds. Where in the US, it is really, we have a very porous system. It's very difficult to get anyone's hands around that. And it leads to such things as really quite exorbitant prices for some novel medications for some really dire medical circumstances, typically in oncology, as we've seen with some medications that have hit the market that extend life 4 months for prostate, some forms of prostate cancer, and cost about $100,000 per course of therapy. And it really has allowed us to really start thinking about how can we put some sort of framework around that to try to keep our healthcare system from falling into the default mechanism of funding very expensive therapies that are like not providing a great deal of health benefit. So there's certainly, I would say to Dr. Phillips, certainly a lot of interest in doing that, and whether or not it can be done from a governmental point of view is challenging. I've said often that the US is kind of costophobic in terms of even speaking about costs. One great example being the US Preventive Services Task Force, which is not allowed to consider costs in their deliberations, although it's in their congressional mandate to actually do so. It's a bit of a third rail, but it does remind us that we all as researchers in this area need to keep going forward, because people do need guidance about this, and they need to know when they're really operating on the margins of cost effectiveness at the detriment of our healthcare system. So, so thank you for that prompting question, Dr. Phillips. I want to also give another question to Dr. Lau. This is from another anonymous attendee who says, you mentioned one feature of the program is barrier removal via the executive committee team. Could you give an example of a successful removal of a barrier?
Oh yes, there are so many. But in talking to project teams, both the project teams that I work with outside of Caring Wisely and other project teams as well, probably the number 1, 2, and 3 barriers that people list are their time, the ability to get the data that they need to, one, figure out what the current state is and then measure their intervention. And then probably number 3, the biggest barrier they've had is modifying our EHR to be able to enable the work that they're hoping to do. And so the executive committee, by funding the Caring Wisely program, gives us funds to hire our own data analysts, have our own financial analysts. We do have time built in from Apex analysts as well to help with Apex builds. And in fact, Caring Wisely projects are marked as Caring Wisely and can oftentimes go ahead of the queue of other tickets that are submitted because they are supported by the executive committee, and the executives want to ensure that those projects get done over the course of the year. So that is probably the most common example of barrier removal on behalf of the executive committee. A more specific example of a barrier removal is I spoke of the integrated spine service. This was actually an outpatient-based project, a collaboration between orthopedic surgery, anesthesia, and pain management to really help better manage patients with complex lower back and upper back pain that wouldn't necessarily be surgical in management to begin with. And as they were expanding their referral services, they realized that this very small clinic space that they had really didn't allow them to effectively collaborate with all the interdisciplinary team members, which also included physical therapy. And they actually needed more clinic space to sustain and expand their program. And for many of you perhaps on this webinar know that, if you request extra clinic space, that request may go somewhere, but perhaps there isn't a positive response back because everyone wants more clinic space. And we were successfully able to grant them more clinic space. So they have clinic space in Mission Bay, Mount Zion, and also Parnassus in the Spine Center. So that is also, again, a commitment on behalf of our executive committee to try to ensure that these projects are given the necessary runway possible to hopefully ensure their success.
Great, thank you. I wanted to circle back to Tracy a little bit, because this conundrum of trying to get the preferences and values from a pediatric population are really fascinating. It's really important, but it's also interesting because certainly the quality of life of parents is really important to take into account because they are acting as surrogates on behalf of their children, but also they're bearing the brunt to a lot of degree on adverse health outcomes that their children experience. So I was hoping first, I want to use that as an opportunity to commend you for tackling this really difficult problem, but also letting you a little off the hook in terms of thinking that it's not really all about the children, but also about the parents. And so can you expand on that a little bit about what we know and what research pathways we might go toward to try to better integrate the experiences of parents into decision making and the value equation for pediatric populations?
Um, oh, Thank you for your question. So we actually survey by including questions about on what parents think about these diseases, and we included that as an attribute actually initially, and we since we're still going through analysis, I can't really say definitively yet, but what we've seen is that parents seem to value their kids' condition more than the impact on family. So we asked a battery of questions on the impact of family. We also treated that as an attribute and varied it to see if the impact on family changes the decision-making process or change the value of the levels within each attribute for parents. And that's not evident in our study. They valued more what their child could go through hypothetically. And in the literature, I would say that it's difficult to tease out the utilities for parents and pediatric health state. And that's the problem with the biases asking adults or asking parents to answer questions and preferences for pediatric health state, right? And I think more work needs to be done to tease that out. And I don't quite have a perfect answer of how we can move forward regarding that aspect yet.
Great. We have another question for you from an anonymous attendee who says, you mentioned otitis media has been the standard proxy for pediatric dental caries for 20 years. And do you know how otitis media was chosen initially?
Yes, so it was chosen by a group of researchers at the National Institute for Healthcare Excellence in the UK. And before we started our study, we actually managed to get in touch with the person who first published on using otitis media. And she had said that at that time, they did a qualitative evaluation of diseases out there and determined that otitis media is one that's the most similar to childhood caries.
I want to, in our just final minutes, I'm going to just share my screen. I want to make sure that everyone knows that the Center for Healthcare Value also does some research in the realm of education. We've talked about research, we've talked about policy, we've talked about systems improvement. We've also done some studies in how giving randomly assigning medical students at UCSF cost information about breast cancer screening, how that might change what they would recommend in terms of a health policy about breast cancer screening. And this was a study that we recently published showing that giving students cost information does change their attitudes and beliefs about what we should be spending on a population level. I do want to remind you that coming up, the Institute of Health Policy Studies has a monthly health policy grand rounds that is going to be March the 24th at noon. And we're very fortunate to have Lisa Simpson, who's the president and CEO of Academy Health, be our speaker for that session. So please mark your calendars for March the 24th at noon. I also want to make sure that you know that we have an ongoing high value care seminar, an elective that is every Tuesday from 12 to 1 until April the 6th. We're in the middle of our seminar now, but we have some great speakers coming up, and we would love for everyone to join us. We have Mike Rabo, Vinay Prasad, Chris Moriarty from Dell Medical School, Kat Lau, whom you just heard today, Ari Hoffman, and Rita Redberg, who I know is in our audience today, talking about various aspects of high value care from various perspectives. So I encourage and invite you all to join us for that seminar. The CHV has a website that's very easily accessible. So please look at the website for all of our upcoming events and seminars. And so again, I want to thank you all for joining us for this inaugural UCSF Health Services Research Symposium. And thank you for your time and attention. If you have any questions about what we've discussed today, please feel free to send them to me directly, and I will forward them on to our panelists, or you can contact them as well. So thank you very much for your time and attention, and take care.